So it's really my pleasure to introduce Dr. Segev, who I'm so happy accepted our invitation to come here today. Dr. Segev is a professor of surgery and population health, and he's the vice chair of surgery at the NYU Grossman School of Medicine. He's also the and NYU Langone Health, and he is also the founding director of the NYU Center for Surgical and Transplant Applied Research, and which is doing tremendous work here in our field in our city. Dr. Segev was the first to demonstrate the survival benefit of incompatible kidney transplantation across the United States, and is responsible for the first HIV to HIV transplant in the United States back when he was at Johns Hopkins. He was also the first to demonstrate poor immunogenicity COVID vaccine in those breast patients, which has been so important for our field. And for this work, he received a letter of recommendation from Dr. Fauci. His NIH-funded research includes kidney exchange, desensitization, long-term donor risks, access to transplantation, expanding transplantation, including HIV-positive donors, racial and geographic disparities, which we care so much about here in Brooklyn and at Downstate, post-transplant outcomes, COVID vaccine, and the intersection between transplantation, gerontology, and cognitive decline, which we had the pleasure to discuss with him last night. He has an undergraduate degree in computer science and graduate degree in biostatistics, and that has led a lot of his focus on novel statistics and mathematical method for simulation of medical data analysis and to the benefit of all of healthcare. A lot of surgical residents, it seems, and the transplant surgeon know him as the Winter Symposium DJ in transplantation, but Dr. Segev has also published over 900 peer-reviewed research articles, and he's ranked #1 worldwide in the organ transplant expertise and influence by Expertscape. With that, I thank you for being here, and I welcome Dr. Segev to the podium.
Good morning. Thank you for the opportunity to share some stories with you and to take the 5 train more south than I usually do. So today I'm going to tell you some stories about work that we did on Capitol Hill. Hopefully stories that have a generalizable message of how we can take things from let's see, does this mouse work? No, though I have to use this. We can take things from the clinic. Ooh, look at that. Take things from the clinic to the research lab, to the media, to the Hill, and then back to our patients. And so I've done a lot of work at local level, state level, transplant community level policy, but I'm going to tell you 2 stories of things that we did at the national level in congressional policy. Just so you understand sort of how transplant is governed, the congressional level law that governs what we do is called the National Organ Transplant Act, or NOTA, and that was written in the mid-'80s. It's congressional, meaning if you want to change anything in NOTA, you have to go to the congressional level. Below Congress is HHS, and we have our HHS policy is called the Final Rule, the Organ Transplantation Final Rule, and so that's the lower level of transplant policy. And then under HHS is the Organ Procurement and Transplantation Network, the OPTN, now run by a group in Richmond, Virginia called UNOS. So some people use UNOS and OPTN interchangeably, but they're not. And OPTN makes a lot of the policies that we follow. So we have 3 levels of government policy making. But remember, I told you the National Organ Transplant Act is congressional, and so I'm going to tell you 2 stories of how we changed congressional law. And when you think about changing congressional law, this is sort of an important statistic to remember, that every year more than 7,000 bills are presented before Congress, and just a handful of them become law. And so getting something across all of that requires kind of an organized, novel, and creative way of thinking about what we do as patient providers, right? Like, this is, I'm a transplant surgeon. I'm not a lobbyist or a political scientist or anything like that. But how can I think about what impacts my patients and take that to the congressional level? I'll start with my acknowledgments first. This is our research team, now half at NYU and half still back at Hopkins. I came to New York about 2.5 years ago. And there's a lot of trainees there as well. And so for those of you who are trainees, remember that the work of trainees is really what drives a lot of this stuff. And the bills that I'll tell you about had a lot of trainee involvement, to the point where one of my trainees, right before he started medical school, got to go to the White House when Obama signed one of the laws that we wrote. And so the pathway I'll talk about today is getting inspired by the clinical work that we do. That's me operating, but I'll assure you I don't usually lean so far forward, but the photographer made us do that so we would get in the picture. To the research lab, to the media, which is how to get the attention of lawmakers, to Capitol Hill. And those of you familiar with I'm Just a Bill, it's basically I'm Just a Bill gives you the formula for how to do this, but it's a little more complicated than that. The first bill I'll tell you about was called the Norwood Act, named for Charlie Norwood, who was a lung transplant recipient and part of Congress. So what inspired us to write the Norwood Act? What was impacting our patients that we wanted changed nationally? And that was the fact that we have a lot of incompatibility in transplantation in this country. And so how many people, just out of curiosity, know what a kidney exchange is? A handful that work in transplantation. About 20 years ago, nobody really knew what a kidney exchange was because it was illegal. A kidney exchange, imagine that you have a living donor, but they're the wrong blood type, or you have anti-HLA antibodies against your living donor and there's a positive cross-match or something like that. The concept of a kidney exchange is, well, maybe this person can give to that person, and this person can give to that person, and so we can make two compatible transplants result from two incompatible situations that would not have led to transplantation. And we got the idea that we really could help a lot of people by doing this across the country, but there was this National Organ Transplant Act that I told you about, which said that it was unlawful to transfer any human organ for valuable consideration. And this is the way lawyers say you can't buy and sell organs. And I wish lawyers would have just said you can't buy and sell organs, but instead they used this phrasing. And when we asked the Department of Justice, hey, what do you think of kidney exchanges? Do you think that these things violate NOTA? After a couple months, we got a little short letter back that said, maybe. That's not something you want to hear when you're considering doing something like that to patients. So there we are, getting inspired by something we think will help our patients, and now we need to do the work to convince Congress to change NOTA to allow kidney exchanges. So interestingly, when I was at Hopkins, one of the things I did as junior faculty was to do a congressional fellowship because I was interested in changing policy. And we were able to do it part-time so I could still operate and then spend a lot of days on the Hill interacting with the American Political Science Association and with the people who really run DC, which are the legislative assistants or the LAs, the staffers down there. And I helped work in one of the offices and helped work on some of the some of the bills that were going on at that time, maybe a small bill you might have heard of called the Affordable Care Act. And so I learned a lot about sort of how to get Congress's attention and how to get Congress to do things. And a smart Health LA at any congressional office will ask you 3 questions when you say you have a health-related thing. One is, how many people are we talking about? 2, what will be the benefit if we do this? And 3, what is the political risk? Okay, so by benefit if we do this, we mean how many lives will be saved and how much money will it cost or will it save? Because every bill that you propose gets a Congressional Budget Office score. And if the CBO score is not encouraging, that means that it's going to cost a lot of money and not save a lot of money. And that those bills with bad CBO scores are very, very hard to get across the finish line. Fortunately, in transplantation, does anyone know how much it costs Medicare every time we do a kidney transplant? It's about negative $500,000. Why is that? Because Medicare has to pay for dialysis. And transplantation is way cheaper than dialysis. So our CBO scores were amazing because every transplant we do, we actually save Medicare money. But it's really important to know that anything you do policy-wise is going to be looked at from a cost-benefit perspective as well. And then when we say what is the political risk, remember that politicians are not policy makers. They're not policy scientists. They're people who represent the people who voted for them in their constituency. And so politicians care about, will my constituency benefit? Will my constituency be harmed by this? And part of when we take things nationally is convincing the folks in Kentucky that the folks in New York are not going to steal all of their organs. And we face that a lot because, there's this sort of, oh, well, the big cities are going to steal everything from the small towns. So the thing we did to take this to Congress is we knew we needed to answer these questions. But we didn't have answers for any of these questions. And so we put together a study, which fortunately got published in JAMA. And it was interesting because this was a simulation, a data simulation study. This is basically computer science. This wasn't medical. And when we sent it to JAMA, JAMA wrote us back and said, we usually do not publish papers of this sort at all, but we realize the potential clinical importance of this and the policy importance of this, so we will work with you to get this into the hands of our readership. And what we wanted to answer was, how many incompatible pairs were there in the country? How many people were there kind of sitting around who would have gotten a transplant except their blood type O and their donor is blood type A or something like that, or they're HLA incompatible with their donor? And the problem is that we didn't have a registry of these because a lot of those got kind of dismissed at the kitchen table. They're like, oh, I'm looking for a live donor. Their brother says, I would donate to you. And they're like, oh, well, you're the wrong blood type, so I guess that's not going to work out. So we didn't have a registry of incompatible pairs. We didn't know how best to match them. And we need to, if we, again, take this to Congress, which represents the entire country, we need to convince them that we have a matching system that will not just favor New York and disfavor Kentucky, but will favor everyone equally. We didn't know how many lives would be saved if we did all of this, and then we would be able to figure out, if we could figure out how many people would benefit from this, we'd be able to figure out how much money Medicare would save as well. So I have a background in computer science. I did a lot of simulation when I was younger. I'm married to somebody who has a foreground in computer science and does a lot of simulation now. And so we took on this collaboration. She had never worked in medicine or transplantation before. We still have a collaboration. We actually co-direct the new center at NYU that we founded a couple of years ago. It seemed like a good collaboration when our first paper that we ever wrote together got into JAMA. So what we did was we used fundamentals of computer science and medical simulation called random draw simulation. And what we did is we modeled people and the family structures around them, and we used data we knew about how HLA gets passed on and how ABO gets passed on and the relationships between donors and recipients across the country, et cetera, to model for patients potential donors that they might have. Now, if you have 0 potential donors, you're not going to benefit from a kidney exchange, so we don't model those. But we model people with maybe 1 potential donor, 2 potential donors, et cetera. And we put them through what's called a Monte Carlo simulation. And again, we do simulated donors that they might have. We do a simulated medical and psychosocial workup, a simulated ABO test, a simulated cross-match, et cetera, drawing on data that we have from all sorts of national sources. In transplantation, we have a national registry, so we really know sort of as much as we possibly can about how these things work in our transplant field. And when we went through this simulation, if somebody ended up with a healthy and ABO and HLA compatible donor, we put them into a bin that we called direct donation. And if they didn't, we checked the other donors for eligibility. And if none of their donors were eligible, we put them in another bin called potentially for kidney exchange or kidney paired donation, which is what we called it. And we ran this simulation until about 6,000 people landed in the direct donation bin. And that's the number of direct donation live donor transplants that were done. And then those that were left over in that other bin were the ones that we could make an assumption about would have undergone a transplant had they found a compatible option. And then we used what's called integer program optimization, and we used that to take all of the incompatible pairs. So it turns out every year there are thousands of incompatible pairs in this country, thousands of people who come forward, have a living donor who is healthy and willing but is HLA or ABO incompatible. And then how do you take all of those 1,000 and find sort of the best matches for people? And without going into the math of integer programming optimization, I can assure you that there is math that lets us find the optimal number of transplants that does not disadvantage certain geographic areas, that does not disadvantage any racial groups or anything like that, that in an equitable way can optimize the potential of these exchanges across the country. And this was what we needed to take to Congress to promise people that nobody would be disadvantaged by this. And it turns out that we estimated that we would be able to do more than 1,000 transplants every year in this country through kidney exchanges, and that is about 20% of the live donor transplants we do in this country. So that's a huge increase in live donor transplantation that was blocked by the fact that we had this law that said we couldn't exchange for valuable consideration because that's the way that lawyers speak. So then we had this JAMA paper. How many people here think that 23-year-old Princeton grad legislative assistants from Capitol Hill read JAMA? They don't. They read the New York Times, they read Politico, they read actually Congressional Quarterly, CQ, which is like that's their JAMA. So we needed to get media attention for this. We were a little bit fortunate that Time Magazine named us Innovators of the Year for doing this kidney work. And so we got some attention through Time Magazine, but we also then used that to leverage to all of the other publications, all of the other newspapers across the country. And this was an era where we would actually go to the magazine stand and buy 100 copies of Time Magazine and hand them to legislative assistants on the Hill to take back to their offices and read about it. And so once we got the attention of mainstream media, then we went to the Hill. We drafted this bill. I actually drafted all of the words for the original draft of the Charlie Norwood Act. And basically, the key section of the bill said, for the purposes of this section, kidney paired donations. Now, we called them kidney paired donations instead of kidney exchanges because remember, the original law said you couldn't exchange an organ for valuable consideration. So we didn't want that word exchange anywhere near what we were doing. But we said that KPD not considered to involve the transfer of a human organ for valuable consideration, found support, bicameral support, bipartisan support. These are the senators that supported it. These are the folks from the House that supported it. I'll get into, in the next story I tell you, I'll get into a little more detail about what it's like trying to get these folks to sign on to a bill. But ultimately, this bill flew through. Same year it was introduced, it ended up passing through both branches of Congress and went to the president. And this young man, which was me, or younger man, and this other younger man, which was the president at the time, signed the bill into law and made this possible. So then we take this and bring it back to our patients. And that's really, really important to remember, is that if you go through all the effort to change policy, you're only a quarter of the way there. You've got to take it back to your patients, implement the policy. The next story I'll tell you about this becomes really, really critical. And we need to be able to bring this to our patients. So there were a handful of centers kind of doing this rogue before the Norwood Act passed. And you see those are these little numbers before 2006. When the Norwood Act passed, the use of kidney exchange in this country blew up, as the kids would say. And it's because we were able to create a national multi-center kind of clearinghouse for kidney exchanges. And we were able to exchange across the country, allowing somebody in New York who had a very, very rare need for, had a weird anti-HLA profile, had a rare need for somebody, and maybe that donor was only in California, and we needed to be able to connect all of these folks together. And today we do about 1,500 or so kidney exchange transplants per year. And remember, I told you that that's what the simulation estimated we would be able to do with this. So we promised this to Congress and the Congressional Budget Office, and actually it became true. And today, again, now it's closer to 25%, but about 20 to 25% of the live donor transplants that we do in this country come through kidney exchanges. The work that we did impacted work in other countries as well. The Canadian system adopted what we did in the United States, and they do a bunch of exchanges. These are European countries who are in slow levels of adoption of kidney exchange across Europe. There is an Australian kidney exchange program based on the work that we did in the United States, and there's even a kidney exchange program in Ahmedabad, India, that has started to grow, that is impacting the rest of that country as well. So not only impact for our own patients here in the United States, but a lot of countries had kind of similar laws that came about in early efforts to prevent organ sales that were blocking them or hindering them from doing kidney exchanges, and this impacted them as well. So that's story one. Taking on Congress to make a change in the National Organ Transplant Act to allow kidney exchanges to happen, and the impact of that. And hopefully you see that the impact of it is quite meaningful to the people that I take care of on a regular basis, and made the tremendous amount of effort that it took to get that passed worthwhile. The second story I'll tell you about is the HOPE Act, or the HIV Organ Policy Equity Act. I'd like to say that I was clever enough to name it the HOPE Act, but it was a 23-year-old Princeton grad working as a health LA in one of the congressional offices that suggested this, and suggested that we introduce the bill on Valentine's Day, which we did, which was adorable. But here's another story of something that was impacting our own patients, and how we modified a congressional bill to make this possible. So, what were we seeing? What was I seeing in my clinic, in my operating room, that was inspiring me? Well, it turns out that since the 80s, remember that's when NOTA was written, HIV is a very, very different disease. Today, they estimate that if you have HIV, your life expectancy is the same as if you had not had HIV, which is really impressive. It turns out if you have HIV and kidney disease, that's a bad combination. People with HIV on dialysis have half the survival as people with HIV, as people without HIV on dialysis. So it is a bad combination to have HIV and be on dialysis. Well, we'd want to transplant them, right? As transplant surgeons, we want to transplant everybody. And the option that was available to folks was what we call a D-R+. So the donor is HIV negative and the recipient is HIV positive. And in this country, thanks to seminal work that was done out of UCSF by Peter Stock, it was made possible for us to transplant people who were HIV positive, so HIV positive recipients. And kidney transplantation was growing quite well, and liver transplantation was growing quite well also. And based on those data, based on hundreds of transplants that we had done in the United States, we actually discovered, observed, confirmed that if we transplant somebody who's HIV positive, their outcome is actually equivalent to transplanting somebody who's HIV negative. So if they're on dialysis, they do quite poorly, but if we transplant them, they do actually very well, meaning that their survival benefit, the benefit they get from the transplant, is actually more than the benefit that somebody who's HIV negative gets from the transplant. And I'll tell you, I tell that fact very naturally because I told that fact about 500 times in DC when every single person I talked to said, well, why are we even transplanting people with HIV? Don't they just do really poorly? And we actually needed to do the science to show them that actually they benefit more from a transplant than their HIV negative counterparts. Well, what about HIV positive donors? It certainly would make sense that if somebody's HIV positive, they should be able to get a transplant from somebody who's HIV positive. And when I was starting out on faculty, I was greatly inspired by a colleague, Elmi Mueller in South Africa, who had this incredible story. If I had another hour, I would tell you her whole story. It's fascinating, and it involved her almost going to jail, her almost losing her medical license for doing this. She was in a scenario, so in the US, if you have kidney failure, you get dialysis, right? Medicare pays for dialysis. Dialysis is really, ESRD is really like the only, national healthcare system that we actually have. If you're in South Africa, and you have kidney failure, and you can't pay for dialysis, you die. And a lot of the people she was taking care of were HIV positive, had no means to pay for dialysis, and she was seeing them die. They also have a much higher HIV prevalence in her region than we do in the United States, and as a result, she was seeing a lot of people die as potential donors, and nobody was using their organs for transplantation. There was no law there prohibiting it, but it was kind of like accepted medical practice that you wouldn't do something that insane, like give somebody an organ from somebody who's HIV positive. Well, she said, this is stupid, and she did it. She did it in 4 patients. They all did incredibly well. This got out to the media, this got out to the medical board, et cetera, and they went after her hard. She sent her case report to New England Journal. New England Journal published it, and then all of a sudden, she's the hero of South Africa. So if you're going to do something that might land you in jail, see if you can publish it in New England Journal first. But we were really inspired by the work that she did, and nobody else in the world had ever done an HIV to HIV transplant. And so I wanted to do it in the US, and I found myself up against the beautiful National Organ Transplant Act again, which was written in the mid-'80s when we were in the middle of the AIDS scare. And I will read you the wording from it that said, preventing the acquisition of organs that are infected with the etiologic agent for acquired immune deficiency syndrome. We didn't even call it HIV then. That's how old that congressional bill was. And somebody made the mistake of putting medical practice into a congressional bill. Please don't do that, because then we have to go to Congress when medical practice evolves. And that's exactly what we had to do. And I was like, oh, here we go again. This is going to be another 3 years of my life. And so we go from the clinic to the research lab. And we say, well, what questions do we need to answer? And there were those same questions that we had before. How many people were we talking about? What will be the benefit if we do this? And what is the political risk? So Brian Boyarsky, who was a post-bac sort of on his way to medical school at the time, had come to my lab and he said, I'm interested in a health policy project. And I said, how would you like to take on Congress? And he said, that sounds fun. And I said, this is exactly the kind of spirit we need taking this on. And so we put together a paper, not in JAMA this time, unfortunately, but we put together a paper trying to estimate how many HIV positive donors there would possibly be out there. Again, this was a scenario where we didn't have the data, because if somebody with HIV is declared brain dead at some outside hospital, they know that they're not allowed to be a donor, so they don't even call the organ procurement organization. And if they do call the OPO is like, we can't use HIV positive donors. Okay, thanks, bye. And that's it, and it's done, and there's nothing recorded about it at all. It's just done. And so we needed to use national data. We used data on a large cohort of HIV positive individuals. We also used death data from across the country to look for people who died in a manner that would have been consistent with organ donation, but happened to be HIV positive, et cetera. And we again estimated how many donors are we talking about, and it turns out that it was quite a few. How many lives would be saved? How much money would Medicare save? And remember, every time we do a transplant, Medicare saves money. So then we took this to the media, and when you're working in the HIV/AIDS space, you get a lot more help than when you're working in the kidney exchange space. There is a very strong lobby in DC for HIV/AIDS care. There's actually a White House HIV/AIDS office that sets priorities for what they do with HIV that year, et cetera. And the year that we were doing this, the White House priority was to destigmatize HIV. And I want you to think about that and how we played that priority when we tried to get our bill passed. So we got the attention of the New York Times. For those of you trying to get your work into the media, the number one thing that you need to remember when taking things to the media is patience. And I mean patience like be patient, but also patience like the people we take care of. So look at the first two words of this article. The first two words of this article are the name of a dude in LA who was willing to be interviewed by the New York Times, talk about the fact that he was living with HIV and that he was waiting for an organ transplant and not doing well, and how this bill might be able to improve his life. And this got on the front page, above the fold, New York Times, and I even got the quotation of the day. So another take-home message is learn how to very succinctly summarize the things that you're trying to get into the media in a few words, because the media likes 10-word little sound bites. And my quote of the day was, the clock is ticking more quickly for those who are HIV positive. So with this media attention, again, we went to the newsstand and bought 200 copies of the New York Times and passed them out on the Hill. So to get into a little bit more detail for this particular story, we went to Congress. So we talked to people in the Senate and the House. The Obama administration had this national AIDS strategy and the AIDS office, and we talked to them as well. We went to HHS and HRSA about it, and then we had a lot of support from professional groups. In particular, the HIV and AIDS groups had a ton of lobbying power or advocacy power on the Hill. These are all of the groups who gave us their Washington, D.C. advocacy teams to help push this bill forward. The bill was drafted March 2012. The legislative assistants from Boxer and CAPS's offices helped us draft the bill. When you write a medical bill, it gets sent to HHS for what they call a technical assistance. It basically is Congress saying, hey, HHS, can you read this to make sure that we're not going to kill people and that this all makes sense? And then we revised the bill and we started the CBO score process. And we worked hand in hand with the CBO to remind them that we save money when we do these things. We got the attention of a lot of legislative assistants. We had a briefing where there was actually a guy who had been transplanted, one of the very first HIV positive recipients in the country, whose job had been a legislative assistant at some point in his life. So he kind of resonated with all of these kids running around Washington, D.C. But the way we really filled the room, we had like 150 people, standing room only, which is crazy for getting a bunch of legislative assistants together. How did we fill the room? We fed them. So the same thing that brings residents out also brings legislative assistants out. This is Congresswoman Lois Capps, who was a former nurse who sort of understood some of the medical issues when we were doing our briefing, and then a few other people that we had speak at this briefing and kind of inspire the LAs to really want to take this forward. Again, bipartisan, bicameral support. These are the main offices. If you get Senate interest in something, the bill is considered more powerful than if the House is driving the bill. So you really want the Senate driving the bill if you possibly can. Again, from both sides of the aisle in the House, it's not that the right side of the aisle there was not supportive of this, but that's kind of what the House looked like at the time that we were bringing this bill forward. When you introduce a bill to Congress, you only have that year for the bill to go all the way through committee, get signed, and get enacted. And if you miss that, then you have to reintroduce that bill the next year. And in transplantation, we've had these frustrations. The Medicare Drug Coverage Act took 10 introductions over 10 years before that bill finally made it across the finish line. So we introduced this on Valentine's Day as recommended by one of the LAs. It went through the Senate committee, came out of the committee quite quickly, and then got unanimously passed on the Senate floor, then was handed to the House E&C committee, and they just sat on it and sat on it and sat on it. And we were getting really frustrated looking at the date, thinking, well, the last thing we want to do is have to do this all over again next year. So we went to the White House HIV/AIDS office. Remember that office I told you about, whose stated goal it was that year to remove the stigma associated with HIV. And I went to talk to them and I said, look, this is hung up in House committee. You know, obviously the House, the Congress doesn't really officially talk to the White House, but they all drink together on the Hill. And so they all know each other and they can really help move things along. And they said, look, that sounds really interesting, but it's not really what our goal is this year. And I said, oh, that's interesting. Who of you here has considered whether you want to be an organ donor or not? And they're all like, yeah, well, of course we considered whether we want to be an organ donor because we have to decide when we get our driver's license if we're a donor or not. And I said, you have to decide when you get your driver's license if you're a donor or not. Do you know who doesn't have to decide if they're a donor or not? People living with HIV. And they're like, whoa, this is incredible. This is real stigma associated with HIV, is that everybody living with HIV, when they go to get their driver's license, does not get to make that decision. In fact, is told, we don't want your organs, they're worthless. And so all of a sudden, we had some buy-in from the White House AIDS office, and somehow this bill came out of committee, got introduced into the House under suspension, which means like, look, Senate approved it, so we're going to approve it. We're not going to mess with it. And it got out of the House, and then Obama signed it 9 days later and made that possible. And this is Boyarsky here getting to accompany the team to the White House to watch the bill that he really helped push get signed. And so then we have a bill, we have to take it back to our patients. One of the things that so when HHS reviewed the bill, they said, we're worried that you're going to give everyone in the country HIV. I don't know why they were worried about that, but they said this has to be done only as research, and then the HHS secretary reviews it every year and decides when it's going to become actual clinical practice. And I was like, okay, only as research, I can live with that. Fine, you have to get an IRB if you're going to do HIV to HIV transplants. It's probably good anyway, because then we'll learn, et cetera. But then they said, you know, the HHS and NIH have to come up with the criteria for what is research. And then I had in my mind, like, okay, so 15 years from now, the NIH is going to like create a committee that's going to decide what the rules are, and we're not going to be able to do anything in that time. So we actually put into the bill a 2-year time limit that this is research, and NIH and HHS have 2 years to publish the research criteria. And guess how long it took them to publish the research criteria? 2 years minus 10 minutes. Literally, they published it the day that it was due to be published, according to this congressional law. So again, remember to build in ways that things get implemented so that they don't just get passed and get stalled. Finally, we were able to do the first HIV to HIV kidney transplant in the United States, and the first one outside of South Africa, and the first HIV to HIV liver transplant in the world, because they weren't doing liver transplants in Elmy Mueller's transplant center. So that was exciting, and we kind of opened the door, and word got around in the HIV community. And, you know, when you work as a transplanter, you feel like you're in this really, really micro niche of medicine. I was getting, because my name was all over the media, I was getting unsolicited emails from people living with HIV across the nation showing me their little driver's licenses and pointing to the little heart that showed that they were organ donors. And this, like, I forgot how much this impacted, like, the 1 million+ people in the US living with HIV, which kind of made me forget how much we impact actually as transplanters, the entire community. Like, everybody knows about transplantation because it's something that everyone is in some way kind of involved in. As a reflection of how he actually keeps up with the things that he's involved in, President Obama found out that we did this first HIV to HIV transplant and sent us a really nice note congratulating us on doing it, and, you know, remembering that he had signed the congressional bill that made it possible. In fact, the year he signed the bill, there were only 53 bills that passed into law that entire year. And, you know, when you're a president, they give you a bunch of pens for signing bills, because you sign a bill with like 8 different pens and you distribute those to the people who were involved in the bill process. And he said that he had way too many pens, and he was in the Oval Office, he said he's very thankful for our work so he could get rid of 8 more of those pens. Taking this back to our patients, remember it was required to be research. So then we went to the NIH and we said, okay, listen, this is required to be research. Cough up some dough. And we got funding to study the donors and their antiretroviral resistance patterns and things like that, their viremia patterns. We got funding to do a national multi-center study of HIV to HIV kidney transplants and liver transplants, and now we're actually on the years 6 through 10 renewals of both of those. This has been a huge national effort. You're looking at here the kidney centers and liver centers who've participated in this national study. A couple of years ago, we published the first report of HIV to HIV kidney transplants, the largest report that had ever been published, with a comparison group of HIV-positive recipients who got HIV-negative donors. Graft outcomes were spectacular. We published our liver results as well from the pilot study. Now we're getting our liver results looked at by top-tier journals for the final study that we had. And so we were able to start to provide clinical data on what it means to do HIV to HIV transplants. And then the HIVologists are actually very interested in what we're doing because, remember, we're doing this weird thing where we take a donor with some strain pattern of HIV and we take a huge inoculum of that HIV in the form of a liver or a solid organ, and we put it into a recipient who has a different strain pattern of HIV. And there are questions of superinfection, viral dominance, and all of this, particularly given that the recipient is already on antiretrovirals when they receive the transplant, et cetera. We have done a lot of interesting basic science looking at these questions. This is one particular study that we found very interesting because we looked at 22 recipients who got these transplants, including one who had a breakthrough HIV infection, and we found no detectable viral strains that had come from the donor. So there was no evidence of the donor HIV strain pattern in the recipient. So showing that either the recipient viral strain was dominant or that because they were on antiretrovirals, there was no further superinfection or anything like that. That was very interesting. We've also done a lot of qualitative work or more sort of patient-facing work to understand people living with HIV and their willingness to accept organs from donors who had HIV, their willingness to become donors, as people living with HIV, and the willingness here, you look at like 80% willingness to be a deceased donor, 62% willingness to be a living donor. This is way higher than the general population. In fact, there are special reasons that people living with HIV are drawn to becoming donors, signing their donor cards, et cetera. We did a really interesting sort of ethnographic evaluation of all of this. They feel solidarity with the HIV positive recipient. They want to reduce the stigma associated with HIV. They want to give back time that they feel is borrowed time. They feel an obligation to science because they're alive, even though a lot of the friends that they had earlier in life died from HIV, and so they're very grateful for that. We've also looked and we've been able to study, and we continue to study, the HIV latent reservoir. For those involved in HIV science, you know that is the one thing keeping us from finding a cure for HIV is this latent reservoir. And again, we have patients who we can take lymph nodes out of, during the operation and really study things that would not have been possible to study in anybody else. We also got the idea that the HOPE Act did not specify that the donor had to be a deceased donor. So we made it possible for us to let living donors, people living with HIV, become living donors. And why not? Well, there are a couple reasons why nobody had done this before, even not in South Africa. One is because of HIVAN, HIV-associated nephropathy. But it turns out when we studied this that people on modern antiretrovirals do not have HIVAN if their HIV has been controlled. And the old antiretrovirals were nephrotoxic, but the new ones aren't particularly nephrotoxic. So if you have somebody with very well-controlled HIV who's never had a lot of breakthroughs, who's on modern ART, they have equal kidney function to somebody who is HIV negative, and they have equal risks down the road to somebody who's HIV negative. And we did a whole study on this to identify the phenotype of people living with HIV who could become possible living donors. And then we announced that we're doing this. And within about 4 seconds, I got an email from Nina Martinez, who had been watching all of this because she had acquired HIV as an infant from a blood transfusion. She was an HIV epidemiologist at the CDC and had dreamed her whole life of showing people that HIV in 2020 did not look like the death sentence that it was in 1980, but in fact, HIV in 2020 was a marathon runner who was healthy enough to actually donate their kidney to somebody else who needed a kidney transplant. And so we went through a lot of discussions with her about what this means and what we know about the risks and what we don't know about the risks. Like, look, you're the first person in the world who has done this. We have no idea what's going to happen. She was gung-ho because she really understood all of the science behind it, and she became the first person in the world to donate a kidney living with HIV. If you want more details about that aspect of things, I was fortunate enough to give a TEDx talk on this. You can find this on the interwebs and spend 20 minutes learning a lot more detail about the bill and sort of the whole process of bringing it back to this first. So, stepping back a little bit, what can we learn as medical care providers, not people who work on Capitol Hill, to impact policy around us? Well, learn the policies that are impacting your patients and think from the trenches. Think from what you do as a clinician. Let that inspire you. And then learn the science of how to do the kind of science that impacts policy. Learn how people think who are policymakers and publish for the policymakers. I didn't care if any patients read the study that we did about kidney exchange. I wanted policymakers to read the study we did about kidney exchange. Make connections in the media. I can tell you that all the connections I made through the HOPE Act, when COVID hit and we had a couple of JAMA papers showing that our transplant patients were benefiting from the vaccines, but they were in a sea of a million other COVID factoids that were out there, I just called all my friends who I knew from all of those articles that covered the HIV to HIV transplants, and I said, hey, I got another thing for you. So make friends in the media, learn how to talk to the media, learn how to express your science in 10-word sound bites, and then learn how, whatever level of government you want to impact, learn how that works. If you have time, do a fellowship or just go visit an office. If you're looking at state government, go visit a state policy office and learn how they work, learn how advocacy groups work with advocacy groups and societies and legislative assistants to help move these things along. But don't forget that once you get that thing changed, work equally hard, if not harder, to bring it back to the trenches so that you can actually impact the patients that inspired you to do this from the beginning. So I'm going to leave you with one last thought, which is that as people in healthcare, a lot of things should piss you off, and if you can, pick one and fix it. Thanks.
All right, I don't know what to say. I have no questions. It's just phenomenal, and so thank you so much. You know, this is just lifetime achievement. If I had it, I would just give it to you right now, but I don't have it. So anyway, let's open it up to questions.
Dr. Segev, thank you so much for accepting our invitation and giving this amazing talk. It really is inspiring and impactful. I often tell residents that the one thing that made me really taught me how to be a surgeon is when I was a figure skater, because I was terrible at it, and it taught me to fall on my butt and get back up. And I think now, as a surgical educator, if I look at the impact of your career, I think that surgical residency really doesn't prepare one to step on this podium and make this talk. And so what do you think we have to do to better prepare surgical residents to have an impactful career in the paths that you've led? Yeah.
And medical residents.
And medical residents.
All residents. Well, and beyond that, trainees for every aspect of patient care, right? I think we get very focused on what we do in the day-to-day. And we, as I said, a lot of things do piss us off. And we just kind of accept them because I've got another case to do this afternoon. I've got clinic tomorrow, et cetera, et cetera. We don't need to accept them. Now, I'm showing you two success stories. There are a lot of failure stories as well. We can't fix everything, but the things that are most fixable are the things that I've decided to spend time trying to fix. There are things that are not fixable or that are just so hard to fix that I know that that's not going to be something I can impact. But these both seemed, bipartisan, like saving Medicare money. These seemed like kind of the kind of things that we should be able to get through Congress, even though it's nearly impossible to get things through Congress. And even if you are working day to day on the clinical aspect of it, find the things that are important to your patients and collaborate with people who work on the policy aspect of it. When I was at Hopkins, I was faculty in the School of Public Health as well, and we had a lot of people in the School of Public Health who do policy things and who are interested in policy things and who wanted to collaborate with us on these things. The HIV societies had a lot of people who wanted to collaborate with us on these things. I didn't go to the Hill every day. I went to the Hill maybe 10 times in the period of 2 years. Boyarsky went to the Hill every day. So find people whose job it is to do that and have them do that. You also need to find some funding for this kind of thing. But again, societies have funding for advocacy. And if you find just the right thing to piss you off that you're going to fix, you actually will be able to fix it. But I think that we give up. We have a very sort of, passive view of how we could potentially impact the general policy, the things that will impact not just our patients that we're looking at, but the sort of the greater community of patients. And I would say don't have that view and collaborate with people who are dedicating their entire lives to not having that view. You can keep operating, you can keep going to clinic, you can keep rounding, seeing patients, but bring those challenges and why it's simple and why it's important. And you're the one who can express these things better than anybody else. When it came time to talk to media, I would not let our advocacy people talk to media because they didn't know, they couldn't say it in 8 words, and they didn't have the legitimacy of it all. So use what we need to be involved in when we need to be involved, and then let our other sort of policy collaborators take it from there.
Questions? Dr. McFarland is the program director.
Thank you so much. This heroic work is very inspiring, like I can't tell you. Just from a clinician point of view, when you transplanted a different strain, did you need to do anything with the medications, review, change, etc.?
It's a great question. So most people we transplant are already virally suppressed on antiretrovirals. We only have like a 3-day window to evaluate a donor and their entire antiretroviral resistance pattern, et cetera, to make changes in the recipient. So one of the things we do is we take whatever we can from the donor history. And if we know that like the recipient is on sort of level 1 antiretrovirals and the donor was on sort of next level antiretrovirals, we'll change the recipient up front. But then after we do the transplant, we do a lot of more ART resistance testing on the donor. And then we tweak those things in the recipient as well. And we've seen some breakthroughs, but they've not been superinfection breakthroughs. They've been breakthroughs when the recipients just had a self-imposed medication holiday.
Excellent. Thank you so much.
I think I said I wouldn't go ask a question, but I have a question.
Good.
Do you see a day where you will go back to the Congress to, propose another bill for xenotransplantation?
Well, we are working with regulators on a regular basis now for xenotransplantation. Fortunately, xenotransplantation is not forbidden in congressional law. Xeno is a collaboration, let's say. Some might say fight, but let's say collaboration between us and basically the FDA right now. And actually, FDA has been quite supportive of the efforts of xenotransplantation. And the NIH has also been supportive of, the desire to do research in xeno. Another example is we do Hep C positive to negative transplants all the time, and we never had to get congressional permission to do that. Do you know why we didn't have to get congressional permission? Because what was Hep C called in the 1980s? Non-A, non-B hepatitis. It didn't exist in the 1980s, really, and so it was never forbidden by congressional law. So fortunately, most of what we have in transplantation, we don't have to deal with Congress.
So this concludes the medicine runarounds portion of the symposium. I would like to thank the organizers and inviting Dr. Segev to give this wonderful runaround. So let's join me to give